everyone. My name is Jan Losby. I'm also at CDC with the Division of Unintentional Injury Prevention in the Health Systems team, and it's a pleasure to be with all of you today.
And I know that I've shared my name, but where I sit is I am the lead for policy and partnerships within CDC's Division of Unintentional Injury Prevention. Clearly, the opioid epidemic is something that's causing a lot of harm to individuals and families and communities throughout our country, and CDC, as the nation's public health agency, is of course very much invested in working to address and prevent this epidemic moving forward. And in doing so, of course, we want to recognize that we are just a part of the solution and that there are so many other partners and stakeholders that are engaged in this, and that includes, of course, providers and all of you who have dialed into today's webinar, and so that's why we want to make sure to extend a thank you to all of you. I know that I've had the pleasure of speaking to some of AMSA's leadership in the past few months, and I know that this is an issue that you all have highlighted as an important need for which there's need for more information and resources, and we definitely appreciate your interest and also the leadership that you all have shown in regard to working on this epidemic. So on this first slide, before we progress to the next one, I will just say that for purposes of today's conversations, any discussion and or views that are shared by my colleague Jan or myself should be construed as our own and not representative of CDC as an agency. So now that that fun disclaimer is out of the way, if we could advance to the next slide, please. And so before we start talking about opioid overdoses in particular, I thought it might be helpful just to orient all of you in terms of where we sit and where this work is housed with CDC as an agency, because I know that it could be a little bit tricky to discern government agencies, ourselves included. And so this is just a quick slide to orient you to some of the topic areas that are addressed within CDC's Division of Unintentional Injury Prevention. Our division is one of 3 divisions that is comprised of the National Center for Injury Prevention and Control for CDC, and that Injury Center is one of 12 different centers across the agency as a whole. Next slide. For the next few slides, I'll be going into some of the data and the public health burden on overdoses attributable to opioids because, of course, this is part of what serves as our main motivation as a public health agency. But one of the things that I wanted to highlight is just to tell you a little bit of the backstory to this. CDC as an agency has been tracking this epidemic for over a decade, and it was in the early 2000s that some of our scientists started taking a closer look at the data when they noticed a substantial increase in the number of deaths that were attributable to unintentional poisonings. And I think it's worth mentioning that in one of the first articles that was published on this emerging issue, there was a 2006 analysis that looked at the dramatic increase in poisoning mortality rates and compared it to the sales of opioid analgesics nationwide. It was then that scientists from CDC noted that an overall goal should be to identify ways to decrease deaths from opioid analgesics without diminishing the quality of care for patients and the legitimate need for pain management. And I wanted to start by saying this because I think that this is something that has carried throughout today in terms of our work that we're going to be highlighting for you all, and something that I think is particularly a point that would find resonance with all of you who are joining. So on this slide, I won't belabor it too much because I think that the pictures and the upward graph lines show the compelling story of what has been ongoing throughout the epidemic as we have been tracking it. Next slide, please. To put CDC's work in context, of course, we work in conjunction with our federal partners and external partners, including you all within this space. And I'm hoping that all of you are aware that this is a priority topic for Secretary Burwell, and she had recently released her 3-pronged approach in terms of stemming the opioid epidemic. In order to maximize CDC's role in particular, we wanted to capitalize on our strengths as an agency, and so what we decided to do, just given the enormity of the epidemic, is to come up with what we're calling our 3 pillars of CDC activity. These are the pillars around which we center our work as an agency, and I'm going to talk through each of them briefly. The first is to improve data quality and track trends. The second is to strengthen state efforts by scaling up effective public health interventions. And the third is to supply healthcare providers with resources to improve patient safety. With regard to the first pillar that's referenced here, I think that one of our leadership here says it well, where this is really the bread and butter of CDC as an agency, and that is capitalizing on our epidemiology expertise, using the science in order to pivot to prevention strategies in public health. With regard to the second, one thing I wanted to make note of is that with the majority of funds that are appropriated to our agency by Congress, they go out the door to state and other public health entities. And so one thing I wanted to make mention of is in conjunction with a release through a press call that Secretary Burwell had done on August 31st, we had announced that across what we call our overdose prevention and states effort, CDC is now funding 44 states and Washington, D.C. in some capacity to scale up their efforts to reverse the epidemic as it is presenting within the state borders. And so if there are questions for later on in our conversations, we're happy to go into a little bit more detail with the work that's being done through those programs. But briefly stated, I think it's really to capitalize on the levers that exist at the state level. And so those would include maximizing the use of prescription drug monitoring programs as a public health surveillance and as a clinical decision support tool, working to embed some of the recommendations within community and insurer mechanisms as they exist at the state level, evaluating the efficacy of state-level policies that were intended to address the opioid epidemic, and giving states an innovative means to use the funds to address what is going on that they see on the ground. So whether that's working with law enforcement, whether it's honing in on specific communities where they see overdose rates, we wanted to give them the flexibility. So that's just another component of our state programs. One of the most recent programs that was announced was to further enhance the collection and the analysis of both morbidity and mortality data. This cuts across both prescription opioids as well as illicit opioids, knowing the rising concerns with heroin overdose rates as well as overdoses attributable to synthetic opioids such as fentanyl and its analogs. With regards to the last pillar, I think that this is where a lot of our comments are really going to be centered. We'll be sharing with you CDC's recent release of the guideline and talking through some of the other resources that have been created to help providers, including all of you who are on the call today. Next slide. When we talk about our CDC guideline, we make mention of dual public health issues, and so there's one of chronic pain as well as one of overdoses that are attributable to prescription opioids. And so the one statistic that I wanted to just call to your attention is that first one there, where about 11% of Americans experience daily chronic pain, and I think that that's something that warrants notice. Next slide, please. Great, thank you. And here is just a juxtaposition of data that I think is helpful to highlight for purposes of today's conversation as well, that the amount of opioids prescribed has quadrupled from 1999 to 2014, but the pain that Americans report remains unchanged. And again, I think that this is part of our motivation in terms of the development and release of the guideline. Next slide, please. And on this slide, I know that you were able to see some of the numbers in the graph that I showed a few slides back, but unfortunately, overdose deaths have increased in lockstep with prescribing increases, and we have about 165,000 deaths from overdose related to prescription opioids since 1999. And again, this really undergirds the need for clear and consistent recommendations. Improving the way that opioids are prescribed is one of the drivers to today's opioid epidemic. Next slide, please, and at this point I'm going to transition it over to my colleague, Jan.
Thanks very much, Joann. So I'll pick it up here, and I just wanted to provide some background. Many of you may be aware that CDC released its prescribing guideline in March 2016 in both the Morbidity and Mortality Weekly Report and also in the Journal of the American Medical Association. And the purpose of the CDC guideline for prescribing opioids for chronic pain is to provide recommendations for the prescribing of opioid medications for patients 18 years or older in outpatient primary care settings And the recommendations focus on the use of opioids in treatment of chronic pain, meaning pain lasting longer than 3 months or past the time of normal tissue healing. And it's important to note that the guideline is not intended for use in active cancer treatment, palliative care, or end-of-life care. And the primary audience intended for the prescribing guideline is primary care providers, such as family practitioners and internists. It includes physicians, nurse practitioners, as well as physician assistants. Next slide, please. So why primary care providers as the focus? And here we can see the overall numbers of opioid prescriptions by specialty. And primary care, again, family practice, internal medicine, and general practitioners provide the largest numbers, nearly half of opioid prescriptions compared to others. And the growth in prescribing rates among these providers has been above average. We also know that primary care providers report receiving insufficient training in pain management, as well as report concern when prescribing opioids. Next slide, please. Here's a diagram of the development process of the guideline itself. So CDC conducted a systematic literature review of benefits and harms of opioids and developed the draft guideline using the GRADE framework. It's the grading of recommendations, assessment, development, and evaluation to rate the quality of evidence and the strength of recommendations. CDC obtained input from experts in pain management, primary care, opioid prescribing, substance use disorder treatment, as well as from medical associations, organizations, advocacy groups, state agencies, national partners, and also our own CDC's Injury Board of Scientific Counselors. CDC also gathered feedback and input from clinicians, patients, and the general public through webinars and by posting the draft guideline in the Federal Register for public comment for 30 days. We received over 4,300 comments, and at each stage through this process, we reviewed and carefully considered and incorporated the feedback. Next slide. In terms of the evidence, there's a lack of evidence that opioids control pain effectively long-term. The risk of serious harm increases with opioid dose, and up to a quarter of patients receiving opioids long-term in a primary care setting do struggle with addiction. And so what can providers do? First, do no harm. Opioids are not the first line or routine therapy for chronic pain. When opioids are used, they should be prescribed with the lowest effective dosage, and exercising caution when prescribing opioids and monitoring all patients closely. Next slide, please. In the next series of slides, I'll review the recommendation statements. The 12 recommendation statements contained in the guideline, they're grouped into 3 conceptual areas. First being determining when to initiate or continue opioids for chronic pain. The second conceptual area is opioid selection, dosage, duration, follow-up, and discontinuation, and assessing risk and addressing harms of opioid use as the third conceptual area. Next slide. Determining when to initiate or continue opioids for chronic pain. Here in terms of the recommendation statements, one is that opioids should not be considered first-line or routine therapy for chronic pain outside of active cancer, palliative, or end-of-life care. The importance of establishing and measuring goals for pain and function. Also discussing the benefits and risks and availability of non-opioid therapies with patients. Next slide. For opioid selection, dosage, duration, follow-up, and discontinuation, using short-acting opioids when starting with the lowest effective dose and carefully reassessing before increasing, or avoiding or justifying high dosages, and when opioids are needed for acute pain, prescribe no more than needed. And follow up and reevaluate the risk of harm to reduce dose or taper and discontinue if needed. Next slide, please. In terms of assessing risk and addressing harms of opioid use, CDC recommends to evaluate the risk factors for opioid-related harms, checking the PDMP, the Prescription Drug Monitoring Program, for high dosages as well as prescriptions for other providers. So in reviewing the PDMP data when starting opioid therapy for chronic pain, and then periodically checking the PDMP during opioid therapy, ranging from every prescription to every 3 months. Also using urine drug testing to identify prescribed substances and undiagnosed, undisclosed use. Avoiding concurrent benzodiazepine as well as opioids. And arranging treatment for opioid use disorder if needed. So clinicians could consider or arrange evidence-based treatment, usually medication-assisted treatment with buprenorphine or methadone, in combination with behavioral therapies for patients with opioid use disorder. Next slide, please. I'll turn it back over to Joann, who will describe our implementation activities.
Thanks, Jan. So I think as Jan had highlighted, there was a whole lot of work that went into the development of the guideline overall, but one of the things that we wanted to ensure was that it wasn't a document that just sat on the shelf somewhere, but that the 12 resultant recommendations could really be used to inform and change the culture of prescribing practices on opioids, especially for chronic pain management. And so following the release of the guideline, and even while we were working toward the release, we very quickly pivoted toward an implementation strategy. And so in the next few slides, we're going to be walking through some of CDC's efforts in this regard and some of what we know that's already underway. Before doing so, I do want to point out that while we're just giving you a very broad walkthrough of the guideline overall, if you've not had the opportunity yet, we would absolutely invite you to read through. I think that the scientists here within our agency did a phenomenal job in terms of the assessment, the culling, the analysis of the clinical evidence that are available in terms of crafting the recommendation statements in a very specific manner. And so we definitely invite you to read through the guideline following today's presentation. Next slide, please. So here, just given the enormity of the guideline overall, what we wanted to do was come up with these 4 quadrants of activities in terms of CDC's guideline implementation strategy. And those are efforts that fall in alignment with translation and communication, clinical training, health system implementation, and pharmacy benefit manager strategies as well. Excuse me. I'll be doing a quick walkthrough of some of the activities that are underway under these first 2 quadrants, and then Jan is going to give you a little bit more detail about some of the activities underway under the second 2. Next slide, please. So in conjunction with the guideline release in March of this year, we also released a series of tools and materials, and these are meant to be a distillation of what could be deemed as highly technical information that is in a more suitable format for a variety of audiences. And so one of the audiences in particular are patient materials. Even though the guideline was written with the primary care physicians as the target audience in mind in terms of operationalizing the recommendations. Of course, the rationale for why we engage in this activity is really to improve patient outcomes. And so some of the patient materials that were developed are what you see reflected here: graphics and messages, fact sheets, and other means for distilling the information in a more easily digestible format, including infographics. Excuse me, next slide, please. We also released a series of fact sheets to really hone in on some of the specific topics that we wanted to parcel out as a part of the guideline recommendations. And so one of the first ones that was released, and all of these are available on our website, is an overview of the prescribing guideline overall. There was one that went into more details about assessing the benefits and also risks associated with opioids, how to best utilize prescription drug monitoring programs, some fact sheets on calculating daily dose of opioids or morphine milligram equivalents, and in particular, given the increasing concern of neonatal abstinence syndrome, there was one fact sheet in particular looking at the implications of opioid pain medications in conjunction with pregnancy and/or with pregnant women. And/or of women of childbearing age. Next slide, please. And here's an overview of some of the clinical tools that were developed. And so I'm going to go into a little bit more detail later about our checklist. But in terms of the pocket guides, these are two that I wanted to highlight for you all. The most recent was an overview pocket guide of the guideline overall, and this was released in conjunction with the Surgeon General's office when he was launching his Turn the Tide campaign. And the more recent one is a pocket guide on tapering. This was released in conjunction with a webinar that CDC had conducted on this topic as well. Next slide. And here you have our checklist for prescribing opioids for chronic pain. And I think what I thought was such a smart undertaking of our scientists here was that prior to the release of the guideline, once the recommendations were in final format, we worked with Atul Gawande's group to come up with an algorithm of sorts that really could walk clinicians through from the assessment phase to the prescribing process for opioids. And so if you're not yet familiar with this, I would absolutely recommend that you visit our website and download this particular document, because I think that it does so well the walkthrough of operationalizing the recommendations within the guideline into something that could be implemented within practice. Next slide, please. Another tool, and this goes along with that second quadrant of clinical training, are a series of webinars. And so one of which is a 7-part webinar series that has been released through CDC's COCA platform, which stands for Clinician Outreach and Communication Activity. And to date, we have completed 4 different webinars, and we have 3 more that we're hoping to have scheduled before the end of the calendar year. My hope is that AMSA has been a part of the listserv, and so that you all who are on the call have received information about the webinars when they've been convened live. But if not, all of the webinars that have already been convened and those that are planned are archived on our website for, I believe, a minimum of 2 years, hopefully longer, and you have the opportunity to submit for continuing education credits after completing each of the webinars. On this slide, you'll see the 4 topics that have already been addressed, and some of the ones that are forthcoming are about risk mitigation strategies, assessment of opioid use disorder and referral to evidence-based treatment, and effective communication strategies for providers in speaking with their patients about opioid therapy. The webinars were something that we had planned to do all along, just because we thought that this would be a good format in which to train clinicians as well as students across different disciplines. And other than the first webinar, which was more of an overview similar to what you all are hearing today, the subsequent webinars really focus on what is the most interactive format. And so CDC has partnered with the University of Washington on these webinars, and on webinars 2 through 4, we actually had clinicians who were presenting a case study, because we thought that this was a good interactive means to figure out how best to operationalize these into practice, and with an opportunity for Q&A that was following. One of the target audiences for this webinar series, in addition to clinicians writ large, were medical schools. And the rationale for that is that toward the end of March of this year, the White House had released a press release in which there was a voluntary commitment made among 60 different medical schools who had voluntarily pledged to incorporate some aspect of CDC's guideline within their 2016 academic curricula. And so I definitely invite you to do a quick Google search, see if your particular institution is on there. But that said, I don't think that that is an exhaustive list of all the different universities and academic institutions who are working in this regard, just the ones that had signed up with that voluntary commitment. But given the commitment and given the timing, we thought it would be great to capitalize on the opportunity. And with our colleagues at the Department of Health and Human Services and with the White House, we convened about, I think, 3 calls with representatives from across the different 60 medical schools to see what kind of tools and resources would be helpful. Some of the feedback we received was to share with them the learning objectives for each of the webinars, to share with them the platform, and I think they were able to participate on the first few webinars, and we received some good feedback from that as well. In addition, I know that students, and want to make a specific point to all of you, are really influential in terms of what the curriculum committees want to do within each of your academic institutions. So to whatever extent you can weigh in with the leadership at each of your schools, we would absolutely encourage you to do so. Next slide, please. In addition to the webinar series, we're currently working to develop what we're calling an 8 to 10 hour learning module. And so these will be comprised of different modules that can be completed in 30 minutes or less. I believe that we're going to be taking a more myopic focus on training specifically for primary care physicians, although it is going to be reflective of some of the content that has already been shared and content that's under development through the 7-part webinar series. Our aim with this is really to come up with curriculum and material that could really match with some of the criteria that physicians who are in practice have in terms of maintaining their licensure through their state requirements. And so we're hoping that this is going to be a useful resource, again, to medical schools, but also for clinicians in practice as well. Next slide, please. And just to give you an overview of some of the tools that are forthcoming, I think one that's going to be of particular interest is a mobile app that currently is undergoing beta testing. One of the components of the mobile app will be a morphine milligram equivalent calculator, and so it'll have a drop-down tab of some of the most commonly prescribed opioids for pain management so that you can easily do the calculations to come up with a total MME. In addition, there are going to be some tips and tools on motivational interview tactics, and again, we really want to hone in on how we can help providers initiate some of what they may deem to be very difficult conversations with their patients about assessing benefits and risks associated with opioids. Another tool that is going to be forthcoming is a pharmacist brochure. Hopefully this will be released in the next month or two. And really what we want to do while we talk about providers writ large, we completely recognize and appreciate the pivotal role that pharmacists play as well. And so we wanted to have a tool that was specifically speaking to them as a stakeholder and a partner. Next slide, please. And at this point, I will turn it back over to Jan.
Terrific. Thanks so much, Joann. If we turn now to health systems and insurer intervention, you can sort of see how these are important system-level complements to the translation and education pieces that Joann just described. So in terms of CDC's efforts in assisting health systems, we have a number of different areas of work. One is looking at clinical quality improvement. So this is to help health systems develop guideline concordant quality improvement processes and to help facilitate adoption and use of the recommendation statements in the guideline itself. We're working with a contractor that will be doing a number of things. First, starting out in terms of actually creating the quality improvement measures. So you can think of these as what a practice might adopt or implement to track and see how they're doing in terms of prescribing. So there might be a quality improvement measure specifically around the morphine milligram equivalent of 90 to see the percentage of patients that are over or below that threshold, for example. So in terms of the quality improvement measures themselves, I mean, it's not just enough to have measures. It's really important that hospital systems will adopt and use these measures. So we're also creating an implementation guide, which would be a complement or a supplement to the measures themselves to help hospital systems, clinical systems identify what are those next steps to take in order to move forward with integrating quality improvement measures into their practice. So, for example, identifying a champion, making certain that the IT department is invested in the work, making certain that there are dashboards or auditing or feedback systems so that clinicians can track their prescribing behaviors over time, and then make adjustments and also opportunities for education and training. So once we have the measures and then the implementation guide, the next step is to really actively work with some hospital systems. And what we're calling this is an opioid quality improvement collaborative, which basically means we're going to intensively support 6 hospital systems to integrate the quality improvement measures into their practice. We're also working on clinical decision supports, and so this is looking at how to translate the content of the guideline into an EHR, an electronic health record, by creating code or artifacts, whether it's alerts or pop-ups into an EHR system. And we consistently hear from clinicians that it's really important that whatever is available to them is incorporated and folded into their clinical flow. And one of the ways to do that is to ensure that the EHR itself is reflecting the content of the guidelines. So we have opportunities to, again, work with some hospital systems that are piloting through their clinical sites, outpatient primary care sites, to implement the guideline and to track outcomes. Next slide, please. Also connected to health systems, we're preparing and we've already launched a coordinated care plan for safer practice. Basically what this does is incorporates recommendations for health system operations and includes clinical content that's closely aligned to the guideline. And it's a good complement to the guideline itself. It's also focusing on safer care for patients that are already on chronic opioid, long-term opioid therapy. The rigorous evaluation is underway, where we have 9 clinical implementation sites and we have 9 clinical comparison sites. So the implementation sites are actually incorporating the clinical guideline into their practice, and then the comparison sites are not. And we're tracking prescribing outcomes as well as some of those process outcomes to really understand what it takes at a practice level to incorporate the guideline into their practice. And then the materials that are developed from the coordinated care plan would then be broadly disseminated and available to hospital systems for adoption. We also, as Joann mentioned earlier in this webinar, we work directly with state public health departments, and these state-led efforts, part of the work that many states are pursuing is actually to improve the integration between EHRs and PDMPs, or those prescription drug monitoring programs that are state-based data systems. Also, states are moving forward with implementation of the guideline into their own, the health systems within their own jurisdiction. Next slide, please. So if we turn to insurer interventions, you think about health systems as one lever at the system level that could bring about change in prescribing. Insurers or payers are another important lever. So in terms of our work with both private and public insurers, as well as pharmacy benefit managers, they can and do foster guideline implementation through improvement in coverage and service delivery payment models, as well as proactive use of claims information. This slide shows 5 potential asks of payers that we're exploring with them. One is looking at the coverage of non-pharmacologic therapies that have good evidence for pain management, such as exercise therapy and cognitive behavioral therapy. A second exploration with insurers is making it easier for clinicians to prescribe non-opioid pain medications with good evidence for pain treatment by eliminating potentially burdensome requirements such as prior authorization. We're also looking at reimbursing, how to work with insurers to reimburse clinicians for activities that improve quality and safety of pain management, such as patient counseling, coordination of care, and checking the patient's prescription history in the PDMP. The last 2 items are specifically related about high dosages and about buprenorphine limits. So promoting more judicious use of high dosages of opioids outside of palliative, active cancer, or end-of-life care, using mechanisms such as drug utilization review to identify potentially risky high-dose prescriptions with feedback to clinicians. Also, you could use prior authorization to make sure that clinicians provide a rationale when titrating opioids above riskier threshold dosages outside of palliative, active cancer, or end-of-life care. And the third area we're exploring is ways to make it easier for clinicians to provide evidence-based treatment of opioid use disorder by removing barriers to treatment, such as removing lifetime limits on buprenorphine for opioid use disorder. And studies do show high rates of relapse when buprenorphine is discontinued. Next slide, please. So as I mentioned, we're working with CMS, so this is the Centers for Medicaid and Medicare, in harmonizing the MME thresholds. So as we mentioned earlier, and perhaps you're familiar with CDC's guideline, it talks about having a 50 MME for caution and then a 90 MME as the higher threshold. And ways to make that the CDC guideline threshold is in alignment with measures that CMS is pursuing as well. So seeing if there's a way to match up those MME thresholds. Also, we're exploring with CMS ways to ensure that there's actually checking of PDMP. So, if this would be perhaps a performance measure that clinicians would be assessed on, then it might be a way to encourage and support checking the PDMP. We're also working with commercial payers. Very often we're exploring ways to connect with large employers as the purchasers of services for their employees and exploring what options there might be to move forward with those strategies that I mentioned on the previous slide. So pharmacy benefit managers are also an important entity in the environment and the landscape of insurers. And we're focusing on the top 3 pharmacy benefit managers. And these are third-party administrators that they do provide services designed to look at drug effectiveness and utilization as well as expenditures. So, if there are ways to move forward with PBMs that are in alignment and in support of the science behind the guideline, that would be a helpful next step. And lastly, states are a very important player in this space. As I mentioned, and Joann did as well, we are working directly with state public health departments, and states do drive prevention efforts. In addition to running the PDMPs that I mentioned, they administer large public insurance programs such as Medicaid or workers' compensation. And some of these states are pursuing ways to look at prior authorization, drug utilization review, as well as patient review and restriction as ways to help ensure safer prescribing and safer treatment and therapies for patients. And CDC is also collaborating with the National Council for Behavioral Health. This is an entity that works directly with state Medicaid directors, and it's another way to really understand what are those policy opportunities at the state level that might be moving forward that are in alignment with the science behind the guideline itself. Next slide, please. And we included this slide. It's just a list of some resources. So there's CDC's website where you can go to any and all and receive the information that Joann described related to translation, as well as the webinars and the content connected to the fact sheet. There's also a CDC Media Toolkit. And we also include links to HHS, the prescription drug and heroin overdose epidemic. There's some information at the HHS level, Health and Human Services, and also the Surgeon General's website we've included here, Turn the Tide. So thank you very much on behalf of me as well as Joann, and we'll see if there are questions.
Thank you so much, Joann and Jan. As a future physician, I feel very empowered after this presentation, and I hope everyone else does as well. We do have some questions in the queue. If you have any questions, feel free to type it in the Q&A box on the right side of the screen. One of the questions we have is, I know that while having a PDMP can be useful, sometimes it does not improve the opioid overdose issue as patients who are dependent end up having their needs met on the street. How do you respond to this?
This is Joann, and I can jump in first, and then I'll defer to Jan to weigh in as well. I think that the question is really timely, and one of the things that I wanted to point to is we actually have a publication. I know that the abstract is now available through CDC's website. I'm not quite sure whether or not the full text is available through Health Affairs, but one of our scientists here, a group of our scientists actually, had just done an analysis of mandatory PDMP laws across states, whether or not they're for what implications it has for states who are implementing mandatory PDMP checks, as well as the implications of pill mill laws. And so that's really to restrict providers and or put in caveats in terms of who is able to prescribe prescription opioids to patients. And so I think that the findings are definitely interesting in terms of looking at what the implications are for prescription overdose rates, but then also looking across for some of the implications for illicit opioids as well. If I'm reading the question correctly, I believe that it's probably along the lines of looking at that nexus there. So I would absolutely want to point you all to that resource that is either already published or is forthcoming, and we'll be sure to follow up with a link to that full publication as well. I think that, it's an interesting question, and we continue to get asked about prescription opioids, illicit opioids, and how we as an agency are looking at it. And I think that we absolutely are looking upstream in terms of prescription opioids being one of the primary drivers of the opioid epidemic, while still recognizing some of the specific needs and somewhat of a different epidemic that's unraveling with regard to heroin and fentanyl. And I think along those lines, we didn't go into too much detail here, given the audience for this webinar, but some of the strategies that are being employed for illicit opioids is for CDC as an agency to work more closely with our law enforcement colleagues at the federal level and working to facilitate better connections between public health agencies and law enforcement at the state level as well. And so some of the examples are working with our DEA colleagues, with the Office of National Drug Control Policy through the White House, and the infrastructure that they have stood up called the HIDAs, or the high-intensity drug trafficking areas, because I think that when we start looking at illicit opioids, I think that we have to broaden the spectrum and really rely on the data sources and the expertise of our law enforcement partners as well. So I hope that that is addressing the question. I know, Malika, there's probably no way for us to do a follow-up, but I'll pause there and see if Jan has anything to add in and or if there's any follow-ups based on that response.
Great. Thanks, Joanna. Yeah, it's a terrific question and great response. And I would just add a couple of things. In addition, in terms of the PDMP, we recognize it's just a tool. It's one tool in the many tools that a clinician could use to inform his or her prescribing decisions. And so we do understand that, with any data system, there are limitations. That being said, we recognize that for most states that do have operational, functional PDMPs, a clinician can look at two of the most important risk factors for a patient. One is looking at high dose, so the MME threshold, to determine across all prescriptions where is a person on their, their total MME. So for the high dose, that's one. And the second, on checking the PDMP, a clinician can look and see if there are multiple providers. So that's one of the risk factors for overdose, misuse, and abuse. If a person is receiving opioids from more than one prescriber, and very often if that information is not readily known, a clinician could obtain that information from a PDMP. And then in terms of what Joann was describing, and the association and the connection between the illicit drug use and prescription opioids, we're continuing to examine and understand what is that transition, how does it take place? It doesn't always take place. We do know at the state and national level, even when prescribing is going down for opioids, in terms of the illicit market, that continues to climb. So it's certainly something that we're continuing to research. We do know that there's an association that 3 out of 4 people who used heroin, for example, in the past year misused opioids first. So in terms of the critical call to action for looking at opioid prescribing, it's really essential that at the point of prevention to see what can be done at the population level and the system level for having appropriate opioid prescribing.
All right, we do have a follow-up to the question. The participant says, I have heard about the idea of warm handoffs so that patients who are found to be doctor shopping can get the help they need. Are there places that have succeeded in implementing something like this?
Sure, this is Joann. I can get started, and I think that by virtue of CDC being very much out on this topic, that we are able to identify promising practices in other places. And so we can follow up with the specific information, but I know that there is, out in Oregon, we actually just had a meeting with some colleagues there, and one of the things that I thought was so beneficial that was brought up in discussion is the warm handoff and the co-location of services. And I think that this cuts across the board, so that for primary care physicians, I know that some of their sensitivity is that if they do happen to identify or think they have identified a patient who may be suffering from opioid misuse disorder and or opioid addiction, the question then becomes, what are those resources? And so whether it's a warm handoff to medication-assisted therapy, or if it's earlier on in the time spectrum where there is a patient who's presenting within their office for whom they want to start with a different non-pharmacological therapy, such as exercise therapy. As an example, are there those services that are available, and what is the access to that? So I think that the Oregon example is absolutely a good one. I think that, it's really tricky, and one of the things that I would say from a policy standpoint is that much of this is largely driven by the health system approach, and so when you have something that's more aligned with the patient-centered medical home model, accountable care organization model, where there's a lot more services and data systems that are sharing information across, I think it facilitates making those linkages, referrals, and directly getting the patients exactly where they need to go. But I'm happy to do some follow-up, figure out more detail about the example that we all thought was fantastic out of Oregon, and send that information forward to you all.
All right, thank you. I think we have time for one more question. How long has the provider role in opioid abuse been recognized, and how long do you think it'll be until we'll be able to really reverse things?
Great question, and I wish we knew the answer. My hope is that soon. Obviously, let me wax optimistic today. What I think is so interesting, not being a clinician myself, but our lead author and a lot of the brilliant minds who were capitalized here within the agency and outside of the agency in the development and release of the guideline, one of the things that they said that has really struck me is that when they were going through medical school, the training at the time was that there is no unsafe dosage of opioids for pain management, and that as long as you are titrating up appropriately and slowly, then there wouldn't be any harm, and there wouldn't be any room for concern. And I think that given the clinical evidence, much of which is analyzed and cited throughout our guideline publication, I know that as science is catching up, we know that that no longer is accurate. But I think that that is something that is a part of the reality, and it's just the nature of science, that we continue to have to hone our recommendations, pivot to implementation based on what we know at the point. Just in working with on another presentation that is forthcoming, I think that it's worth noting that this is something that stems back very far, and that when you're looking at the issue, I don't think that it's anything that is necessarily new, unfortunately, and that, it's something that goes back, while CDC has been tracking this for decades. One thing to make note, I think that there was a publication in November of last year that was written by Dr. Courtwright, who's a historian at the University of North Florida. And so he wrote a perspective in the New England Journal of Medicine on the history of preventing and treating narcotics in the United States. And what Dr. Courtwright did was to detail how around the turn of the previous century, so the late 1800s, early 1900s, he made notes that within some of the literature from that time, there was sharply rising narcotic consumption sparked a reform response. And he described how physicians were using morphine injections to treat pain, and that was the most important driver of the addiction epidemic of the 1870s and the 1880s. And so I want to make note of this, that it's not necessarily new. I think that we are seeing some troubling peaks, and I think that with the rise of the illicit opioids, it's definitely taking the epidemic in different twists and turns, and we're doing our best as an agency to work to address the epidemic. But I think that it is a steady climb. I think that we continue to have to pivot to the most recently available science, the best analysis, and continue to dig and see what are some of those changes that can be implemented. And so, I mean, I say that all not to paint a dire picture, but just to acknowledge that this is not something that is necessarily novel, but that given a lot of the attention that is being played across different gamuts, so public health, members in Congress, administrative leadership, courts as well, drug courts, providers themselves, I think that what we have here is a heightened awareness of the devastating toll of the opioid epidemic, and I think that that situates us really well to pivot to a response across these different multifaceted entities. So that is a very long-winded response, but hopefully it sheds a little bit more light on the context in which we find ourselves today.
All right. Jan, did you have anything else to add?
That was very well said and very, very thorough, so perfect.
Thank you, Jan.
You're welcome.
Again, I wanted to thank you, Joann and Jan, for the very insightful presentation. And thank you, everyone, for participating in today's webinar. National Primary Care Week continues tonight with a presentation with Dr. Czar and the healthcare system, so please join us at 9 p.m. Eastern Standard Time. Until then, enjoy the rest of your day. Thank you.
Thanks, everyone.